Check, 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 check. Check, 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 check. Hello, everyone. We're going to get started in just a few minutes. Please get settled. Microphone check. We'll get started in just a minute here. Okay. Good evening, distinguished guests. Thank you all for joining this UNHLM side event entitled Preventing TB to End TB. This event is co-hosted by the Stop TB Partnership, the U.S. Centers for Disease Control and Prevention, or CDC, and the CDC Foundation. Thank you also to those around the world who tuned in to our live stream today. Before we begin the formal program, a bit of housekeeping in case of an emergency, which we're not expecting. We'd like to draw your attention to the emergency exits in this theater. In the event of a fire or power outage, hazard lights and red exit signs will be illuminated. Please locate your nearest emergency exit and calmly exit the building. In this space, your exits are located directly behind and to the right, kind of in that green room back there. Once you have exited the building, staff will announce if and when the situation is under control. Please listen and follow all instructions. Thank you for your cooperation. Now I'd like to welcome to the stage the Executive Director of Stop TB, Luchika Ditu, who will be the moderator and Masters of Ceremonies for today's event. Thank you.
Thank you very much. So we wanted you to enjoy different venues in New York. So here you are, ready for a movie. No popcorn served, but some beers. Good evening. And it's a great pleasure and honor to partner with our colleagues from CDC and CDC Foundation. And before I start this, I want to say thank you, Anand, and thank you, Sahu, from my team. And I don't exaggerate if I say that this meeting generated probably like 200 exchanges of emails, as well as probably 50 Zoom calls. So I'm very happy you are here, and this should be awesome. And if it's not, we will be very angry. I want to tell you that this is not a real microphone, but I will keep it here with us. And this microphone was given to us from Stop TB by our partners from Reach Ethiopia. And what I want to say, having it here, are two things. First is that we should believe that we can end TB together. It's a moment of hope and a great opportunity for us in TB, and we should let nothing to stay in front of us. The second thing is, I have to say that our colleagues from Ethiopia, I don't know if you are here in the room or you are in the overflow. I think you are here. Can you guys stand up, please? Just a second. Not just because you gave the microphone, but it's because you actually are the frontliners that are doing all the work. And like you are many in this room. And we are here celebrating your efforts, but also being so grateful and humble by you. And I want all of us to give a hand of applause. Woo! Because it takes a lot of effort to carry this in a big box from Ethiopia. Okay, not because of that and so on. We have an exciting event today, and it speaks about prevention of TB. And some of you remember that we did this 5 years ago. And some of you will hear what we I hope we will remember what we discussed 5 years ago. In the opening, we have 3 amazing human beings and friends. And I want to start with giving the floor to Lois Pace. Lois is I want to read exactly and very well the title, the Assistant Secretary for Global Affairs in the Department of Health and Human Services. And Lois, you joined us for several events this week, and I thank you for your big heart for people sick, especially people with TB and HIV. So, Lois, the floor is yours. Thank you.
Hi, thanks for that warm welcome, and I love this venue, actually. I do hope that people are doing well as we're getting towards the end of this very long week, of a long month, over a very long year or few years. But we've made it. We've made it to this point where we are now going to celebrate once again both the progress that we and you all have made in ending TB, and of course, that much more that we are poised to do. So I am excited to be here, and as Uchika said, I have been sort of on the TB circuit more than I ever imagined I would or could be, but I've been quite delighted, honestly, to show up as hopefully an advocate in this space, and in a way that assures you all that the U.S. truly is committed to this effort and to eliminating this disease. So I want to acknowledge the partners, our partners in this event. Obviously, I'm with the Department of Health, which has our wonderful CDC, but we love that we're able to partner with CDC Foundation and obviously Stop TB Partnership. So congrats on reconvening us this year, and congrats in advance for the high-level meeting tomorrow, which I feel has already been a success in that it has really lit a fire again, not just under all of you who are already champions of this cause, but amongst everyone in this city who is hearing these words over and over and over again. It's not just really the day, right? It really has proliferated the proceedings all throughout. So that's great. Kudos to you. I also want to apologize on behalf of Secretary Becerra. I acknowledge that I am often a substitute for him, and he was called back to duties back in Washington. But Secretary Becerra, for those who haven't met him, he's a very strong champion across global health, and TB is no exception. And I think that's largely because he understands and has a big heart for the issues that are most neglected and the communities that unfortunately all too often fall into that category. So if you're an underdog, we got your back at the Department of Health, and so keep that in mind and keep inviting us to things. I'll try not to take too long, but I recognize I'm a bit of a keynote here, so I guess I'll say some things we already know. We already know that you have an estimated quarter of the world's population infected with TB. We already know that you have 500,000 people who are estimated to develop drug-resistant TB every year, and we already know that about a third of all deaths among people living with HIV are from TB. That's important information for people outside this room to have, and so it bears repeating for someone like me who's newer in this space, but hopefully has the tools to make this issue and these efforts resonate outside this room. To that end, again, we're really looking forward to strong commitments that come out of tomorrow. But as I've heard Luchika say, right, it's not just about the words on paper. You know, we all are really excited when we come together and we're like, yeah, we're going to do this thing. We're going to get back to it. And then we go home, and then we have so many other issues that come up for us. And so what I'm trying to take with me is not all the targets and not all of the statements, but rather what happens in the next week, or the next time I see Luchika at a Global Fund board meeting, or the next time I see you all at, you know, the World Health Summit or the World Health Assembly. I expect you to keep me honest, and I expect us to keep each other honest, and particularly our leaders honest who are going to be saying these words tomorrow. That said, as I mentioned, you know, we in the U.S. are fully committed to what we say and do, and I think you'll hear that come through tomorrow. We are looking forward to this declaration that's being put forth as it builds on the progress that has been made. In terms of sort of the unfinished agenda, I think we've had a lot of conversations about that this week, but we as an administration will continue to invest in really important tools and approaches to eliminating TB, and that is everything from research to prevention, diagnostics, therapeutics, and care. So really the full spectrum, and doing that not alone, obviously, but working through partners like everyone in this room. We know that this can't happen at all by ourselves. And importantly, this work for us is rooted in finding the many missing, right? And being sure that we're not just making progress for the sake of making progress, but we're truly doing that for everyone we have not yet reached. I think a lot of us sort of did and reflected on a lot in the years of COVID. And I found myself often saying how important it was to match innovation with access, right? Like that's really when you're truly having an impact. It's not enough to have the newest, shiniest thing, and it's great and quite important to have new drugs or treatments and new diagnostics, obviously, and yet it has to reach the people that need them. And for us, that means historically marginalized and vulnerable communities, whether we're talking about children, again, people living with HIV or other conditions, and obviously healthcare workers on the front line is another important community that we can't leave out. I want to highlight what I know others will speak to today, which is the tuberculosis preventive treatment sort of intervention that really is meant to protect more at-risk groups. And I'm looking forward to hearing more about how that has evolved and how we can continue to make progress in that space. But I also want to celebrate what we have done. So since 2018, we collectively were able to contribute to surpassing the goal that was set to reach 10.3 million people living with HIV who have received TPT. And I think that's an incredible feat that I haven't gotten to celebrate yet this week. And so I am really proud to say those words and know that. And again, make sure that other leaders are aware of how much we're doing. I think so often we make a plan, but we sometimes don't stop to really celebrate, and you all work really hard, and I think that's something that stands out to me in terms of hitting that target and knowing that we can set more targets and reach them in the future. And, speaking of targets, I think one of the things I've heard from this community is not just the importance of setting targets for TB, right, but thinking about the context in which those targets are being set. So obviously, pandemics, and global health security are taking up so much space after so much time. It's not going to go away anytime soon. And I think this group has been really smart to say, okay, well, how can we talk about this in the context not just of HIV, but in the context of outbreaks and pandemics? And so whether we're pointing to lab capacities and what that offers in terms of things like genomic sequencing, whether we're talking about surveillance, whether we're talking about PPE, frankly, we know that TB approaches and interventions have been leveraged most recently for COVID-19, and frankly, we know that the ways we've been able to strengthen those resources and approaches because of COVID-19 could, if done right and well, benefit people at risk for or living with TB. So let's keep up that drumbeat and make sure that the work that you all do remains relevant as things evolve in the global health space. I think where I want to end is really, again, recognizing what can be done and noting that we have a lot, while we have a lot of work to do, we have the opportunity to build on and create new tools and approaches. We know that work doesn't happen without people as the engine who lead on that progress and who can really drive that progress. And so I did really want to pause again and come back to the people in this room, the many champions who are here, acknowledge that the many ways that the U.S. is able to work with ministries of health and otherwise through technical partnerships, whether they be in the research community, whether they be with civil society, whether they be in the private sector and with industry. It's really quite impressive what we've been able to accomplish in TB because of those partnerships, and I just want to really thank everyone who's really dug in. Sometimes the partnerships are hard, right? Like, you can talk about it in theory, but like you said, there's hundreds of Zoom calls that happen before you get to make these grand announcements, for example, that came this week, or pull together these really important events and dialogues. And so I think by, really staying committed to each other, we can really make more of a difference in this space. Thank you again for having me join you and kick things off this evening. I'm really excited to be a part of the dialogue tomorrow. I know, again, it's at the end of a long week, but as I said earlier this week, I think we saved the best for last, and I'm sure you're going to all bring your A game tomorrow. And again, keep us honest to what we commit to so that we remember this day 5 years from now. Thanks again.
Thank you. Thank you, Lois. I think, yeah. Yes, thank you so much. Exactly. Thank you, Lois, for this keynote speech. And great that we need to get in the mood of thinking preventive therapy, right? Not easy to identify to whom, not easy to make it happen, not easy to take it, not easy to follow up, but we need to sort it out, right? Anyway, to put us even more on track, I want to invite Rea Lobo. She's a firecracker, so I hope you can raise the energy level here. She's also a TB survivor, and she's a film producer and award winner, and she's also composing some music. And she composed a TB song that once we performed together, just that you understand the success we had. Anyway, Rea, go ahead.
Thank you very much. I noticed, Luchika, we're all wearing black. It's almost like we're mourning the lack of uptake of TB preventive treatment from 5 years ago, Thank you very much for giving me this opportunity to speak. For some of us who didn't know anything about TB until we got it here, I think one of the biggest shocks I had, other than the fact that we are given a vaccine that is 100 years old, is that we have the TB bacteria present in about 2 billion people in the world. And I was like, what? And it's almost like, we have this bacteria that's flowing in our veins, and we're just waiting for this opportunity for our immunity to become low, for it to be activated, and then we will do something about it. And I didn't quite understand it, And so I met a public health official, I won't say from which country, and I said, why aren't we doing anything about latent TB? And this official said, no, there is no time. We have so much of active TB, there is no time to focus on latent TB, And I said, okay, but it almost felt like latent TB is fueling the fire, and we're just sort of letting it hang around. And let me remind everybody that TB was declared a public health emergency 30 years ago. And so we really didn't do a good job with controlling active TB because we didn't tackle latent TB, And I think that's a huge shame and a huge opportunity that was lost. In order to tackle TB and to end TB, we really, really need to ensure we tackle these multiple facets of treating TB, whether it's latent, whether it's preventive, whether it's active, just all kinds of TB. From a community's perspective, what's really important to us, right? Now imagine yourself, right? Okay, someone comes and tells you, you need to take TB preventive therapy. And you're like, what? Why? I'm not sick. Why do I need to take this treatment? And I think treatment literacy is so important, I remember when I got TB, no one told me what's going to happen. And after I started taking my tablets, I went and my urine was red color. And I was convinced I had internal bleeding, because no one told me that that's going to happen, right? And we really, really need to ensure that we let the community know, give them the power to understand why this is important and why they need to take this treatment. It's not just about, okay, let's give these medicines and just take it. What's going to happen at the end of it is we're going to have something like the DOTS treatment, where we're going to force people to take a pill and make them look into the camera and you take the pill because we don't trust you. It's not that, I think it's so very important to ensure that we do this right, and not try to control everything in this micromanagement way and actually trust people to do what they need to do just by telling them why it's important to do it. We're all adults here, right? The second thing is, we need to understand what the barriers of access are, okay? For someone like me, upper middle class person, comes from an extremely liberal family, I face stigma myself, right? People told me, no one's going to marry you. Can you believe that? I can see all you guys in the room who want to marry me, and I was like, what you saying? And she said, shh, don't tell anyone you had TB. No. People think you're a TB patient for the rest of your life. And I didn't quite understand it, And it's so important to understand community rights and gender. And we have these assessments that are going around in about 30 countries, in over 30 countries. And, we understand what barriers to access are through them. How does stigma impact me taking my medicine? If I have self-stigma, I'm like, oh, it's not going to work. I saw my cousin die, so why should I take the medicine? It's really, really important to really tackle these issues. Are we ensuring that the community has enough access to information, for example? That's super important. It's also important that we find people who the community can trust, right? That is people from the community themselves. Someone who's had TB who says, hey, listen, dude, you really need to take this medicine. Trust me, you don't want to go through what I did, because it sucks. So it's a matter of handling it tactfully and, and just doing it the right way. We need communities to ensure that we have demand generation for TB preventive treatment, right? We need communities to do community-led monitoring. Right now with active TB, we're not able to, I mean, we have so much drug stock out of issues and, all these things going on. And with TPT, it's not immune to getting there. So we need to have those mechanisms in place, which is why, and I'm going to say this a million times over, please invest in communities. Please invest in mechanisms like CFCS. We need more mechanisms like that because, that's where the power lies. I cannot believe in this day and age, I mean, I'm still begging governments to do contact tracing. Oh my God. Like, why do I, as a person who's international award-winning filmmaker, have to tell people to just, if I've had TB and I, just check everyone in my family in a humane and responsible way. I mean, it's so important, and that's the first step. And, if we're going to end TB in 7 years, we really, really need to do this fast, right? And so please, like, contact tracing is so important. Let's just get there. And, in 2018, when the UNHLM happened, we had this target of reaching 30 million people. And I heard our first speaker speak about, how it's really amazing that we had, people living with HIV surpass their targets, which was amazing. But still, we didn't meet the target of 30 million people because we completely ignored the children and the people in the household who have TB, right? The thing is, and God bless the HIV community, those guys are really capacitated. They're strong. They have funds to make them strong. We want funds to make us strong, And it is so very, very important to please, just because the children don't have a voice as loud as mine, let's not ignore them. Please. They need care. We can't let them suffer. I mean, only today we're talking about, drug formulations. Thank God I heard something about liquid formulations. But we need to do more for the children, right? Please, let's get there. And I request the governments of the world, all the stakeholders involved, the donors, my fabulous donors, USAID, thank you, to just please support uptake of TPT. Okay, this is so very important. And we really, really need to work together to make this happen. I've heard governments say, I mean, latent TB is something you can just like put aside and say, okay, it's not troubling me right now, so let's just push it to the corner, right? But, let the next government handle it after 4 years, right? But, we've finished 30 years of it being a public health emergency. TPT is today's problem. It's not the future. Your children will thank you for it. Please tackle TPT now. Please uptake TPT. We need to get there. I wanna be here in 2030 and have not be wearing black, okay? And we need to celebrate that we actually truly at least got close to ending TB. Thank you.
Thank you. Rhea, we take her out of the stage because I'm afraid she will come back to the microphone. So, no, actually, all the points that Rhea made come from a lot of experience and a lot of pain and a lot of, speaking with the others and feeling very well the community and so on. I have a big honor and pleasure to invite the next speaker. It's an honor because I honor his professional career, his integrity, and all the work that you are doing, Salman. And it's a pleasure because I am very happy that Salman is my friend, and he was shoulder to shoulder with me and many others in easy, nice, fun, but also difficult moments. And thank you so much for that. Salman, for those of you not knowing, he's the director of Harvard Medical School Global Center for Global Health Delivery. So he has a lot of weight when he speaks. He lost weight, so a bit less in terms of the real weight. And Salman is here because, not only because of that, but he also spoke 5 years ago in the same meeting in the beginning to kind of set the scene. So it's I'm very interesting. We did, we never obviously checked what the speakers will say. I'm very curious to see what you will say. And I really hope you will generate a lot of thinking in the heads. Salman, the floor is yours.
Thank you, Ruchika. Yeah, I was with Luchika in Geneva when I started a 90-day carb-free diet. So it's such an honor to be here. I'm going to talk today about TB preventive treatment and why we need to do it. And I've got a feeling, I was here 5 years ago, which was amazing, and I think Luchika is going to keep inviting me till I get it right. So I hope I can get it right. So as we think about TB, we're always asking ourselves, is elimination possible, right? And we've had the first high-level meeting, and a lot of us have been talking about this for years. And I think the simple answer is that yes, it is actually possible. It can be achieved using the search, treat, and prevent. We're here to talk about prevent. It's a comprehensive epidemic control strategy for TB that's been used since the 1960s. So it's the reason why in places like the United States, you have a TB rate of 3, or in Canada, you have a TB rate of 2. It's because this is the strategy that it's been used. It's actually been in the United States since 1962. But we haven't been able to use this globally. We haven't been able to implement the strategy and deploy it. Now, at its simplest level, it's, what is it? Well, it includes deploying targeted case finding, and you've seen the stats. I'll show them to you a little bit later, but we're missing millions of people that probably have TB, that are thought to have TB. You want to have prompt and effective treatment, and not everyone gets treatment, unfortunately, even though there have been gains over the years. And then you want to have preventive treatment for people who are at high risk of, after infection, going on to have disease. And this is not rocket science. And again, I want to tell you, it's policy since 1962, but if you dial back, the search part has been there since the beginning of the 20th century. Their active case finding was a critical tool for stopping transmission of TB, because less than half the people who have TB actually have symptoms. So, we often think of weight loss and cough and things like that. That happens, but actually about half the people don't have symptoms. And so you have to actually go look for them. And even before we had medicines, early case detection actually reduced mortality, because people went off to, to be in sanatorium. But basically, this is like one of the critical things, and I think people have been talking about that a lot, like how to do better case finding. And we have great tools for it. They used mobile X-rays at the turn of the century. Today we have mobile X-rays that are a little bit more high tech. They're analyzed by artificial intelligence that can determine if a patient is likely to have TB. So these are very good screening methods. On the complete left, you see a van in Karachi, Pakistan, and you see one of the artificial intelligence programs. But we even have highly mobile X-ray machines that can be carried in a backpack that can be linked to artificial intelligence. And here you see a mobile one being used in Nigeria. So this is like really, we've moved, luckily, since the beginning of the 20th century. And we have technologies to confirm disease. We have DNA lab-based approaches, but we also have this thing that looks like a coffee machine, and another one that doesn't look like a coffee machine, but looks like a telephone, old telephone, that can basically do this in a matter of hours, and you can confirm whether somebody actually has disease. And new technologies around the corner. So we're ready to do the search part, and it just has to be deployed. The treat part, this is a picture of Salman Waxman, who actually discovered streptomycin in his laboratory at Rutgers University nearby, and basically in 1943. Again, if you give people the early treatment with the correct medicines, and you give them the shortest, easiest to take regimen, it stops transmission. Everyone's kind of known this since the 1950s. And now we actually have newer, shorter course treatments for drug-susceptible TB and drug-resistant TB. So again, we're on the way to trying to get this deployed. Not fast enough, unfortunately. We're still missing people, and not everyone gets this. But it's there. It's just a matter of creating systems to do it. And then the last piece of the puzzle is the prevent, right? Which is why we're here. You've got to prevent TB infection from becoming active disease and stop disease transmission by delivering TB preventive treatment. And this is where we actually have significant gaps, which is why we've gathered here today wearing black, although I wore gray, white, and red because I am hopeful. So we have skin tests that we have tools to confirm TB infection. There's the age-old Mantoux test that you see somebody getting up there, but there's also a new highly specific skin test from the Serum Institute of India that has been approved by the World Health Organization. And then we also have blood tests, interferon gamma release assays, and the names don't matter, but there's blood tests. There's ways that you can do it that require a laboratory. There's also ways that where you can take a blood test and it incubates on site, so it's almost point of care. And sometimes infection rates in some places are so high, and you can measure this ahead of time, you don't even need to screen everybody. You could treat everyone in a household. So we have the capacity to actually find out who has this and to deliver it. So since TPT is one of the major gaps, you know, I guess the question is, well, are we missing anything? It's a gap, but is it a huge deal? The answer is, it is a huge deal. And I told you this became policy in the 1960s, and the reason it became policy in the 1960s in most of what we refer to as the Western world is that it's because there was these studies done by the US Public Health Service in Alaska where they showed that Alaska had very high rates of TB. They had a prevalence of 2,000 per 100,000, an incidence of 500 per 100,000. Almost 300 per 100,000 people were dying. And they started screening people in the communities, doing active case finding. They started treating all forms of TB. But what they noticed that despite systematic screening of families in high-risk communities, the search and treat part, they still had people that were popping up with TB. And they were like, how could this possibly be? And so then they realized, and George Comstock was one of the protagonists in here, he realized that maybe people needed to have prophylactic therapy, and they started giving isoniazid prophylactic therapy. They realized essentially that search and treat wasn't enough and that you had to do something that would prevent. And so when they did that, there was this massive drop, and this is the period, if I can make the color there. This was the period where the number of people getting sick with TB was reduced markedly and transmission dropped in communities. And this is like earth-shattering, right? And then not only that, they actually showed that that you could stop transmission. This graphic looks very impressive, and it is because they realized that kids under 3 years old would be kind of sentinels to tell you if somebody in their household or community had TB. And so when they started doing this active case finding, treatment of all forms of TB, and preventive therapy, the percentage of kids that got infected with TB dropped to 0. Can't get more impressive than that. So that's where they realized, and that's why this became policy. And it was never policy in different countries. Now, in countries outside of the Western world. Okay, so we've now heard a couple of times today that there's 2 billion people that are infected with TB. And when you hear a number like that, it probably scares you, and it would scare me, right? And so let's break down TB for a second intellectually so we can figure out what we've got ahead of us. Because if you tell me we have to treat 2 billion people, we should probably go back for cocktails upstairs, right? So, but now let's break it down because it's actually not 2 million people. So there's a bunch of people that, I'm sorry, the slides moved. Yeah, it's the one before. I don't think I can go back. So let me just stop. So that little bottom corner of gray, those are the people that we find with TB. Their contacts, basically, they get exposed to people. And it turns out, to people with TB, and some of them get infected. It turns out that if you're infected, 8 to 10% of people that are new infected, well, it's not letting me, okay. 8 to 10% of close contacts will get TB during the first 2 years after exposure, okay? So visualize that there's 10 million TB patients, and let's say there's, there's about 2 or 3 people in each household or 4 people in each household, and a certain percentage of them that are infected will go on to get active TB. So we have to catch, and it's only, the bulk of it is in the first 2 years after infection. So that means we don't have to treat 2 billion people. That's the good news. We have to treat the close contacts of the current infections, whom we know. We know their names and addresses. So we can actually treat them. And so that's about 20 to 30 million people a year. And that's how we actually came up with how the UN targets came up. So, and where has this worked? Well, it's worked in Alaska. It's worked in places like Russia. It's worked in places like Pakistan, which is probably the Global Fund's greatest project, where they actually, in Pakistan, they funded them, Stop TB Partnership initially, and then the Global Fund came in. They basically did search, treat, and prevent in one area of a city of 20 million people. They covered 2 million people. And in the group where they covered the 2 million people, they had a 25 to 30% decrease. Now, that may not seem earth-shattering, but when you think that the rates in most countries drop 1 to 1.5%, which is glacial, this is earth-shattering. And in the places where they didn't do it, you'll notice they found less people, and it didn't go down. It stayed the same. For those of you that do budgeting, if something stays the same, the cost stays the same. If something goes down, the cost goes down. So, and all these programs are comprehensive, and you'll notice that, and they're simultaneous. They don't say, oh, let's deal with this part first, we'll get to that later. They realize you got to turn off the tap at every point, and if you turn it off, we're done, right? So you can call the program Search, Treat, Prevent. This is the USAID thing. They call it Reach, Cure, Prevent. It doesn't matter what we call it. We just actually have to do it. So the doing it is the tough part, and I just want to talk about some statistics for a second. I want to celebrate what we've achieved, but there's still 4.2 million people undiagnosed. There's about 4,300 people that die every day from a disease that's been treatable since the late 1940s, early 1950s, and about only 20% of drug-resistant TB people get cured. Okay, so that's the search and treat part that is always worrisome, right? Why is the situation like this? I think it's because we've only focused on search and treat, and we always have this constant group of people that are converting and becoming active disease, and we don't ever deal with them. And so this is the gap that I think is why we're all gathered here today, which is that there's a significant number of people that don't get care. We heard from Secretary Pace that people living with HIV, the targets have been surpassed, and that's just incredible. And you know why that happened? That is because PEPFAR made this a mandate and a goal, and they did it. They pushed the pharma companies to lower the prices, and they did it, and they achieved it. But if you look elsewhere, look at household contacts, like kids. Rhea just mentioned kids. Kids, only 40% of them get it. 1 million kids have TB. Only 40% of them get preventive therapy, 40% of child contacts. And if you look at all the other people, the adults, all the people in the community who take it to work, take it on the bus, spread it in their families, etc., because they just happen to get infected, we've reached only 3%. So that, of the goals that were set 5 years ago. So that is kind of dismal. So I know I'm out of time, but I want to just say we have the opportunity. We have new drugs, we have new therapies. This can actually be done. And so I want to end with a challenge, right? So this UNHLM, while we're here, is an opportunity to commit to a comprehensive strategy that includes preventive treatment, and to actually commit, because we know when PEPFAR did it, it actually worked. So I would say that the BRICS countries should include the search, treat, prevent comprehensive approach in their national strategies. They're big countries, and they should include it, and then their sphere of influence will do it. So I think that this is critical, right? The second thing is the Global Fund, PEPFAR, and USAID should only support programs that include search, treat, and prevent, and the delivery of TPT. PEPFAR did it, and they surpassed what we thought they would. The Global Fund for years and years and years have just been funding various programs, and they claim, well, this is what the countries want. But would we fund an HIV program that didn't include maternal-child transmission of HIV? Would we say, oh yeah, that's okay, don't worry about it because that's what you want? No, we'd say that's not good practice. That's not what we're funding. So this has to change, and I think the ministers of health in this room and people working in programs have to demand that, because the Global Fund is, a lot of countries have come together to put money in there, and that's got to be used right to make this happen. And then I think, the WHO and the Stop TB Partnership, and of course, the CDC have to work with countries hand in hand, like with really, really special types of technical assistance to figure out how to make this happen. So let me end there, and I'm sorry, Luchika, I promised her I'd take 9 to 10 minutes, and I probably went over time. Thank you.
Thank you, Salman. Before you go, one thing we need to do all of this. No, two things. We need awareness and people to care at all levels about TB, and we need money. You gave the PEPFAR example very many times, and we acknowledge that. Do you want to look at the budgets?
Well, I would support more money if we do comprehensive. Like, that's the thing. I feel like getting more money without a comprehensive strategy isn't gonna, like, you could throw money at this and it will help. Of course it'll help if you treat active cases. But with more money, you could actually do this. And Luchika's right. When you go to a place and you say, can you do a comprehensive strategy? There's some places that really want to do it, and then they ask, is this going to cost more? And then there's this silence in the room, because the answer is, yeah, of course this is going to cost more, because you now have to treat the context, you have to screen them, you have to do all these things, right? So that's why if it's a requirement for projects from the Global Fund and other things, the money has to follow that. You can't tell people, I want you to do this extra bit of work that's critical to stopping the disease, but I'm not going to give you money for it. It's got to be built in. And I think if I were a donor, I would say, wow, you're doing something different that's worked in other places that actually stops TB. It's worth funding.
Yeah, we will have to work together on a fundraising approach for TPT. But yes, thank you so much. Will be a long and interesting chat. I think we need to arrange a bit the chairs here, as far as I recall, or I can rearrange. I think we are ready for a good interaction, right? You see that Salman planted very good seeds. It is absolutely correct what he said. Let's admit that we in the TB community in the past, or at least when I was used to work in different countries, if you recall, we had strategies in which we didn't really include children with TB, right? Because children with TB don't transmit TB, and it was fashionable to do just the ones that spread the disease. We didn't include extrapulmonary TB. We didn't, because also was not spreading. We didn't include MDR TB because it was too expensive. So we are, I think you should go. Okay, so in a very unconventional manner, I'm very pleased to invite on the stage and to continue this discussion the Minister of Health of Romania and my colleague and friend for more than 20 years, 15 years since we were absolvents of university. The Minister of Health of Brazil, the Minister of Health of Romania, Dr. Alexandru Rafila, the Secretary of State from Brazil, Dr. Ethel Maciel. DG Max is the DG, the Director General of all diseases in Indonesia. And I would like to call my dear and close friend from Nigeria, Dr. Anyaike. He is the Director of Communicable Diseases in the Ministry of Health. And you should come, oh yeah, come. Ministry of Health and Family of Nigeria. So. So I would like to start with you, Dr. Ethel. I know you are in the government and a power of force, a force of nature in the government of Brazil, but also you have a huge experience as a researcher and leading the REDE Institute in Brazil. But also you have concrete experience with TB and other diseases on the ground. And actually, we were chatting a few months ago, and I was speaking about the challenges that we have with preventive treatment, which are related to financing or including them, as Salman was saying, in the programs. But there are challenges related also with the acceptability of it, or the easiness of prescribing it, or people taking it, and so on. How are you dealing with preventive therapy in Brazil right now, and what can you reflect for future?
Thank you very much for the invitation. And sorry, because this week, it's a very long week, and to not be an English speaker and thinking all the day in English, so right now I'm a little bit slowly, but I'm trying my best. Actually, I would like to start saying that I took the TPT by myself when I was a student, because I convert my tuberculin skin test, and I know which is take 6 months of medication each day. It's not easy. But I would like also to highlight, before to enter in the Brazil strategy, that partnership is very important. I'm not be here today if it was not the partnership, and I would like to say that I have the honor to be a student in the Dr. Comstock class, and Dr. Chason here, and for this long collaboration, I have the opportunity to come to my country and teach other students that right now are doing their job in a lot of places in Brazil. So in Brazil right now, we are part of this new government that President Lula put the elimination of TB as a high priority in his government. and he's putting a lot of money in this and change some strategy that we already did in Brazil. As a research, I studied this, and when I was researching a long time ago, until next year, but it has been a long year. I studied why we have the medicine free of charge, we have diagnostics, we have everything free of charge in Brazil. Why we not reach these people and have the TPT like in 100% of our contact? And studying the physician, we realized that they don't think this. We did a research, and the results shows that the physician think that it's not important in Brazil. So they didn't prescribe because they think that it's not important. And how to change this? We have a long way to change the education to the medical students, to change this. So we are working in two strategy. Make this with we have a new program that called like My Plus Physician. It's more physician in everywhere in Brazil. It's a huge program that has the opportunity to put this physician in all of the place. And for this physician, we are working with this education to put TB and other disease that has social determinants in the platform for this education. And in another part, we source other experience in BRICS country, and in South Africa there is a good experience with nursing prescribed the TPT, and we went to the Nursing Council, Federal Nursing Council in Brazil, and we spoke with them, and we convinced that this is a very good strategy, and we get approved. And right now, as a Brazilian government, we are doing this as a protocol to all nurses in Brazil. In Brazil, the TB program in all of the place, they are coordinated by nurses. So this is very important workforce to make this happen with the TPT increase this treatment in Brazil. And just to finish, we have our institution as Fiocruz that is producing ionate in one pill, 300 milligrams ionate in one pill. And when I was research, I conducted this pragmatic clinical trial, and this increased the adherence for the TPT too. So we also are putting in the 3P8 this isoniazide in one pill with 3 milligrams, and this increased the adherence too. So I think this is what we are doing in Brazil. And we think, as the professor said, that BRICS can have a very good, very important role, as we have like almost 50% of the TB bird in the country. And we have BRICS Bank. So we need to convince the BRICS Bank to funding us. And the president of the BRICS Bank is a Brazilian, is the former president of Brazil. So I think we have like the window of opportunity aligned together to work to put TB as a priority in the BRICS and of course in Brazil. Thank you.
Thank you so much. Thank you. Thank you so much for bringing not only like it can work, and these are some things how it can be done, but also some perspectives for funding. And to be honest, and you know that I never leave, Brazil is also the G20 president next year, so I'm not saying that preventive therapy can be a topic of that, but maybe TB overall and looking at perspectives for TB will be important, and thank you so much. We managed to put a panel with perspectives from all continents. And I'm very privileged to give the floor to the Minister of Health of Romania, We still have a burden of TB in Romania that it's above the one in the European Union where we belong. But Dr. Rafila is also a microbiologist, so he's not so he knows very well tuberculosis. So Dr. Rafila, not only in Romania, but maybe in the EU as well, some of the perspectives around the preventive treatment, feasibility, and reflecting a bit of some of the things we discuss here. Thank you.
Thank you. Thank you very much, Lucica. Good evening to everybody. Yes, indeed, in Romania we faced re-emergence of TB until, let's say, the beginning of 2000. And then in 2002, I think we reached 140 cases per 100,000 inhabitants. Then, little by little, we tried to bring the things under control, and now in Romania, maybe was on the fastest reduction of the number of cases, and now we are around 50 or below 50 cases for 100,000. But now this trend, the descending trend stops somehow, and we changed the perspective, and now we are searching cases, and I like very much the presentation before regarding search, treat, and prevent. This is the idea. Incidence per 100,000. We still have, as I told you, between 40 and 50 cases per 100,000, which is a lot. And the number of MDR-TB, it's also one of the main challenges for us. Access to treatment, it's free of charge in Romania. We have DO3 treatment for many, for most cases, but we still face this challenge of people which are not ready to have the treatment, and especially this preventive treatment of TB is very hard to apply in some communities. We have. In Romania, it's very different depending on the region, depending on the economic status of people, and I think our policy should focus on bringing and convincing these people to come and to be part of our effort. I should say something else, which is also very important, is the involvement of the community. Involvement of the community in a public health issue is essential if we want to keep under control problems like TB, and not only. And this change in behavior of people, is conditioned by the interest, the community, and those people who are coordinating and conducting this community to be involved in the public health issues. And we still have problems in this. We are making progress. As I told you, we have information campaign. We are doing a lot of efforts, including with mobile units, which are working all the time and reach this community. We have, let's say, good results. We still work, and we try to change this trend, because TB, it's a very, let's say, particular illness, and we have a problem regarding the circulation of people across Europe, and it's possible to find a Romanian infected person travel everywhere and spreading the infection. So keeping them under control, it's a challenge, and it's a big interest also from the European Union member states to to help to keep this problem under control.
Thank you. Thank you very much. DG Max, Indonesia is the second highest burden country, but I want to tell you something sort of, is not really breaking news, but close to that. You saw in Salman's slide, he spoke about more than 4 million people being missed in 2021. In 2022, the number of people missed with TB is much less, which means that we did a great progress. And for a while already, we from Stop TB predicted, not based on us, but based on some of the data, and Teresa is here, WHO is collecting the data and making them available much more quicker than a year, monthly. So it looks like in 2022, the gap will be below 3 million, so maybe around 2.7 million, something like that, which is probably the smallest number of missing people with TB that we ever registered, which is fantastic. And a big, it was a shouldering by all the countries, right? It's an effort that is done by everyone. But Indonesia did a fantastic job in jumping 200,000-300,000 more people from 2021 and 2022 being diagnosed. Congratulations for that. But I want you to reflect. They are not here, but I need to mention that India is the other one that shouldered big time to that, and they are not here to get any applause. But DG Max, if you can reflect a bit, not only on that, but also on preventive therapy. And when we look at preventive therapy in Indonesia, that's a huge task, right? But it should be done. So thank you so much for sharing your thoughts.
Yeah, thank you, Lucia. I will try to share the program TPT Indonesia. In Indonesia, approximately 22,000 people were on TPT in 2022, or 1.3% of the 1 million targeted population. Currently, Indonesia prioritizes TPT for people living with HIV, all age household contacts of people with TB, and other risk group, especially if they have immunocompromised condition and comorbidities. Our program in introducing TPT for eligible population in the past 5 years remains stagnant. Even though TPT provision has been linked with contact investigation and a short regimen for TPT has been introduced for the last 2 years. We recognize two fundamental barriers to the uptake of TPT Indonesian. First, the suboptimal latent TB infection testing at healthcare facilities and contact investigation, and second, the reluctance of the population to receive TPT, and I think it is a main problem. In addressing the first challenge of latent TB infection testing, we saw a promising accomplishment by integrating TPT rollout with active case finding. In Indonesia, between November 2022 to February 2023, 25 out of 514 districts implement massive TB screening, reaching over 80,000 TB close and household contacts. During this active case finding implementation, we successfully provide TPT to 62.5% of eligible recipients, or 60,900 people. Derived from this experience, incorporating the TPT provision into routine TB screening may be beneficial to tackle the suboptimal integration of latent TB infection testing. To ensure this will be continued in daily practice, the Ministry of Health has officially mandated and encouraged all provinces and districts to conduct contact investigation, diagnostic and district, and provide TPT to eligible population. These efforts are followed by adequate training for healthcare workers to equip them with the necessary skills. For the past 2 years, we have trained over 11,000 healthcare workers across 34 provinces for TPT. For successful TPT provision, a sufficient supply of TST or IGRA tests and the availability of accessible chest X-rays are crucial. Chest X-rays pose a vital role in ruling out TB disease, a requirement for TPT eligibility. However, the rollout test has not been covered by Indonesian National Health Insurance, which hinders the effort of physicians to initiate TPT. Secondly, to increase population accessibility of TPT adoption, we collaborate with community partner, Community Consortium Penabulu, STPI, who are implementing education outreach program for TB and TPT with TSOs and community health cadres in 119 districts and 30 provinces. A big challenge in stepping up this progress is community is how we promote TB infection in TPT layperson, because one does not show symptom when having latent TB. Same said Madam speakers before, resulting in the reluctance of part of the eligible population to receive TPT. There is an opportunity to improve this by developing a specific communication strategy, which is currently being developed by our team and partners with USAID support. This communication strategy will support healthcare workers and community health cadres to educate and persuade TB contact and other at-risk population. I would like to reaffirm that countries have a duty to protect the health of their citizens, and Indonesia will certainly improve effort to prevent TB accordingly. We have commit to contributing to the clinical trial of potential novel and shorter TPT regimen in the upcoming years. However, to further close the large gap in TB infection management and preventive treatment, we need to collaborate together to provide affordable, inclusive, equitable, and timely prevention tools that are accessible to country. While we are accelerating efforts in prevention through new vaccine research and development, we need to ensure universal access and supplies of TPT medicines and auxiliary suppliers, and we must ensure that supply chain for these are reliable. There are the foreseeing challenge that all of us need to solve globally to improve the scale up of TPT. I thank you.
Thank you very much. Thank you very much, DG Max. And DG Max was driving a lot of the efforts, or all the efforts on TB as well as others, including during COVID. Going to our next speaker and making some kind of the link with COVID, you know, during COVID we got a big hit, as you know, in TB, and all our numbers were going backwards. There were few countries in which the numbers, not only they were not going upwards, they were going backwards, they were going upwards. And one of these countries was Indonesia, oh geez, I'm tired, was Nigeria. And that was under your leadership, Dr. Anyaike. And I think Nigeria deserves a big round of applause for the achievements that they were doing on their TB programs. Then, and now, and going forward. It was amazing to report when you go and say, oh my God, the case detections and the numbers of people with TB diagnosed were less and less during the COVID. In Nigeria was exactly the opposite. But I don't want to ask you about that. You have the experience of being in leading the HIV program, leading the TB. Now you have a bigger hat to carry together with Minister Pate on dealing with all communicable diseases in Nigeria. And looking at the TB situation and preventive therapy, what do you think, Dr. Anyaike, can be achieved in Nigeria and how?
Okay, so thank you, Lucica. Good evening, everyone. I think basically we should tackle the problem of tuberculosis looking at just 3 strategies. One is primary prevention. The second one is secondary prevention. The third one is the tertiary one. Primary prevention, what do we mean? Just being able to pass in, people should know that TB still exists. How does it move from one person to the other? And that is what is missing. Then we get to the communities, talk about empowering the community. Let them know that this is how it is transmitted. It would curb the issues of stigma and discrimination. Now, I'll give you an analogy. You come into this room, the whole place is flooded. What do? The first thing you should do is to put off the tap. And that is why I think we should invest very much on prevention. Now that we have missed that first part, the second one is early detection and placing them on appropriate treatment. And that will be a sure way of cutting the chain of transmission. Now, beyond that, I was so excited, when I listened to one of the ladies that spoke here. It does not end there. The other aspect of the tertiary prevention, how do you reintegrate the affected people into the community? Because of the stigma, because they have to live their life. They have to come in and live their life with the whole people in the community. Now, for us in Nigeria, you notice that our case detection has increased, and that is because we have brought in the aspect of taking the intervention to the communities, expanding our diagnostic frontiers, and making sure that we place them appropriately on treatment, and that is the sure way of cutting the chain of transmission. I know you want to hear about TPT, which is also a part of treatment as prevention. What do we mean at this? If I ask every person in this room, what is your adherence rate just to treat for malaria? So many people will take the first day, the second day, they miss it. It's very difficult for someone to take a course of antibiotic just for 1 week. And so what we need to do is to put in those measures. In Nigeria, we did, because we believe in generating evidence. When we looked at the issues of TPT, we now went in and did the scoping with this little fund from Global Fund. Then we were able to find out that there are 2 major issues, one from the government, health worker side, and then from the patients. Someone that looks very healthy, you call the person to start taking drug. You need to convince the person why you should be taking the drug for 6 months. So we came up with that. I said, yes. The next one is, how do you put them into taking the treatment? From the health workers side, we have to certify them for them to reach out to those patients and to make sure that they take the drug. And when we put those things together, we now had to test run. We found out at the instance, we were able to achieve just above 10,000 TPT. But when we now went back and put in our strategy, because we also developed our roadmap, we now notice that we have had up to 120,000. I'm talking of real terms, not by proportion. So we notice that we have given above 120,000 TPT. And with what we have put now in the country, I can tell you that they're going to get more amazing results from Nigeria. So we are not talking about also diagnosing the cases. We're also talking about put other measures to close the tap, making sure that the community is carried along to fight stigma and discrimination, making sure that people adhere to their treatment. We have changed our training protocol to ensure that we bring in the aspect of adherence. Look, tuberculosis treatment is not only about clinical. You need to bring in the public health aspect of managing a patient, because there are a lot of things that determine people contacting tuberculosis, adhering to the treatment, and that is a sure way of cutting the chain of transmission. Yes, tuberculosis can be ended, but we need to walk the talk. We need to put in every measures while waiting for the vaccine to show up on the coast. Thank you.
Thank you. Thank you. And I hope we can give a hand of applause, a round of applause to our guests here. And I would like to invite you to your seats, please. There is an entire orchestration here. Thank you. Thank you. Thank you very much. And I think it gave us hope to see the statements from the ministers, the experience, the commitments, and so on. I'm happy we had Salman here to drop some points for reflection. We had our debate about financing. I am, as you all know, a bit materialistic. So I want to say that we discussed a lot here about we heard the importance of communities and the importance of nursing and the importance of partners. So nothing can be done in ending TB, but also in achieving these targets without the partners. And I would like to invite now for a panel that will be of partners, donors that are part of are expected, and I hope will support the achievement of these preventive targets. And I would like to invite on the stage from WHO, the director of the Global TB Program, Dr. Teresa Kasaeva. From the organization that is the best friend of Salman Keshavje Global Fund, I want to invite Dr. Eliud Wandwalo. He's the head of tuberculosis from the Global Fund. I have the pleasure of invited Mrs. Rebecca Bunnell. She's the acting director, coordinator. She is the acting principal deputy coordinator for PEPFAR. Sorry, Rebecca, for taking a bit of time. So if you can join us, thank you. I would like to invite Mr. Howard Zucker, the Deputy Director for Global Health from the U.S. Center for Disease Control and Prevention. I would like to invite Amy Pope. She's the Director General-elect from the International Organization for Migration. I would like to invite my colleague Sahu Suvanad, the Deputy Executive Director from the Stop TB Partnership. And I would like to invite Dr. Atul Gawande. And I didn't forget, I wanted to leave Atul the last one because he will be the first one to speak, because for many reasons that I will say right now. Yes. I want Atul to start the first because he's representing, as you all know, the USAID, and because USAID is for most of us, or for all of us in the room, the organization with whom we partner in the real way, shoulder to shoulder. You know what I mean? Like, no lip service, not the donor attitude. But also, as we know, USAID is the biggest bilateral, and anyway, I would say the longest, most reliable and sustainable donor of the TB response. So I want to thank you very much, Atul, for this support. Atul. So this is why I invited you the last, but I want you to speak the first. What can USA do to support all these efforts to prevent TB and to increase the TPT coverage? Thank you.
Thank you. And I have some news to give, so I'm delighted to have the opportunity. But I just want to start by saying that when Salman gave that data about what U.S. did in 1950, I want to remind you where the U.S. was at that time. Our GDP per capita in current U.S. dollars was $1,900 per person per year. India's is $2,300 per person per year. We were able to do it at that level of income then. We were able to do it now. And we are a believer at USAID in the comprehensive approach. We preferentially prioritize funding to countries where they've committed to taking on the whole cycle. What I want to say by way of news is that, to start with, the U.S. government is wholly committed to the targets of the high-level meeting, which include the comprehensive approach. To end TB by 2030, prevention cannot be overlooked. Our USAID strategy is a 90-90-90 plus prevention strategy. So it means that we should have 90% of people mirroring what HIV does. 90% of people should be identified who have TB should be diagnosed. 90% of the people who have drug-resistant TB should be on treatment. 90% of the people who have drug-sensitive TB should be on treatment, and we should be reaching the HLM targets, which are 45 million total people on TPT, on TB preventative treatment, 30 million of them on being the non-HIV population, 15 million being the HIV population. And we are committed to that. Given the, so what is holding us back? What's holding us back is costs. The cost of treatment, the preventative treatment, is what limits countries from wanting to take this on. And so today we have a joint announcement with PEPFAR regarding 3HP. So 3HP is the 3-month, once weekly oral TB preventative treatment with isoniazid and rifapentine. It's the shortest of several available regimens, and the price is a challenge, $14.25, compared to the 6-month treatment that can be $3. But people prefer this because it's shorter, you're more likely to get people through the treatment. So what we are announcing today with PEPFAR, Stop TB, and USAID is that we've been able to negotiate a 30% reduction in costs, $9.99. It is huge. Together, PEPFAR and USAID are jointly allocating $25 million to procure 3HP to allow us to treat more than 2.5 million people at risk of TB at the reduced price. That's 750,000 more people than we would have had had we not been able to have that. And that is a huge opportunity. I want to add to this a couple of other things. At USAID, we've been partnering with Virginia Commonwealth University for the last year. The good difficulty with rifapentine, which is the costlier component, is that the drug substance, the API as it's called, is difficult to manufacture and very tricky. And we have partnered with Medicines for All, an extraordinary organization, to work their way through how to remake the process of the raw substance behind rifapentine. And they have been successful in generating a lower cost way and a more reliable way to manufacture it. And so we are now entering a tech transfer agreement for a local manufacturer in Africa to be able to generate the drug, rifapentine. Finally, I'll say this week we've had a number of significant announcements, and I want to highlight our commitment to preventative treatment. We also earlier in this week had a announcement that we are launching a trial of 1 month long use of bedaquiline as a single dose therapy, and you add to that the fact that we were able to announce last week with Stop TB and Global Fund a 55% reduction in bedaquiline. Johnson & Johnson is also developing a long-acting bedaquiline, and this trial that we've launched for the 1 month version will also then become the platform that we can test what would be a game changer, a single dose injectable treatment for prevention of TB that could dramatically simplify what is here. All of this just to say, we can do this. We can do this.
This is amazing. Really, this is amazing. And thank you for these announcements and, this $25 million put into the, the pot for procuring, and the fact that it's a drop in price, we buy more. So this is really great. So thank you very much, Atul and PEPFAR and everyone that works towards this. This is great, great. So please go ahead and put on social media another drop in the price. Yay, yay, yay. Amy, IOM, first of all, congratulations for being the new director-elect of IOM. And for a long time, we in Stop TB, but in general, we are partnering with IOM in different ways, looking at preventive therapy for migrants and looking at migrants' health in general is a big challenge. So, but I think you're up to the task. So why don't you, coming right after Atul, share with us some of the thoughts you have. Now, we have lower prices, shorter treatments, and so on. So please go ahead.
Well, first of all, it's always dangerous to come after Atul, who may be one of my favorite doctors ever. So, and to be clear, I'm not actually a doctor or a public health person, but that's why it was important for me to do this panel today. It's because as someone who has worked on a range of issues, including in one of my prior jobs in responding to the Ebola epidemic, Zika epidemic, when I worked for President Obama, what's clear to me is that if you do not have an inclusive approach, if you do not have an approach that includes migrants when you're trying to manage public health disease, you will not be successful, right? So my view, my organization is working with communities that are extremely hard to reach, and they're often on the move. And this is a major gap when we think about how to stop TB. So first and foremost, it's a plea to all of you to make sure that we're coming up with inclusive approaches. With IOM, our best place where we prevent TB is actually the screening we do for the people who get the opportunity to go and live and work somewhere else in the world. So we have about 1,500 health staff who work for IOM. We're in about 100 different countries. And the number one thing we do with our healthcare staff is the health assessments for someone who has the opportunity to be resettled or the opportunity to go work or to be a student or to go work somewhere else. And so we've screened nearly 1 million people last year for TB, and that is a moment in time where we are encountering someone who may not have otherwise had that kind of screening. So that's an important moment for us, for all of us as a community, to identify and treat people who may have been exposed. But the other place where it really, really matters, and this is a much harder nut to crack, is in the migrant communities, the refugee communities themselves. Number one, these are folks who are on the move. Number two, these are folks who may not actually have access to healthcare or may not know how to access the healthcare. So we at IOM have mobile health clinics. We have set up clinics within migrant communities, and we are working with national healthcare staff to make sure that they are likewise treating migrants and refugees. But it's not enough, right? It's an important effort. We are working, for example, in the Middle East in 6 different countries. I met with a minister of health from Lebanon earlier this week who said, look, we just don't have the capacity with the number of migrants and refugees who are here in our country. So we're working with them to help expand their capacity and to ensure that the host communities, the people who are living with the migrants and refugees, have access to that health care. But the bottom line is that there are major gaps because people on the move are necessarily moving from community to community, and their healthcare records don't always follow them. So it's a place where collectively I think there's much more to be done, but we only do it when we bring people like me who are not doctors, who don't actually know how important this announcement is, but I know it's important from the reaction.
And the number, 30%, is not bad.
Yeah, it's a good number. So bring us to the table so that we can help you part of the solution. Thanks very much.
Thank you. I'm very happy you could make it, also because you are new, and we will try to absorb any new leader of organization that is interested to work on TB. And thank you for coming, and I know you have to leave, so thank you so much for being with us, Amy. Looking forward to continue this. Thank you. And Dr. Bunnell, sorry, normally after the announcement of Atul, it was supposed to go to you, because it was a USAID PEPFAR announcement. So we had to accommodate an early departure. So I'm coming now to you, Dr. Rebecca Bunnell, coming from PEPFAR. We all heard from Salman, and I think we all know that in 2018 there was this big commitment around TPT, and the part of the target that referred to the preventive treatment for people living with HIV was achieved, lagging behind the rest of the people, the contacts and children and so on. So the point is how, how the lessons learned in the previous period will help in scaling even more vigorously, or vigorously finally, the TPT in the next 5 years. Thank you.
No, thank you so much. And I want to start, first of all, thank you for sustaining this long period of sitting. And I want you to raise your hands and thank yourselves as I share with you some well-deserved gratitude that I wanted to convey on behalf of Ambassador Nkengasong, who wanted me to specially recognize the commitment, the hard work of so many of you in this room, ministers of health, people on the front line who have stood by this challenge that we've been given since many decades now. Thank you for what you do in TB. So just wanted to start with that. Thank you. And as Atul has mentioned, we are very excited to be partnering on the new announcement. He's already shared with you that part of our announcements for tonight. I'm going to share another part of our commitment. We did exceed our 2018 commitment, and we're able to reach over 12.5 million people with TPT, people living with HIV. And we would like to go further. And I want to get the wording exactly right. So I'm going to say, so tonight, we would like to make another bold commitment. And over the next 5 years, PEPFAR will aim to detect 2 million active TB cases. And by so doing, we will cut in half projected mortality from TB in people living with HIV by preventing at least 500,000 deaths. And we're going to do that by accelerating our efforts to reach people living with HIV with new innovations in diagnostic modalities. And I wanted to thank Salam. I can't quite see where you are, but thank you so much for sharing such a great presentation. And we all got to see the photos of some of these new modalities, some of these new innovations, both in terms of chest X-rays and gene expert, et cetera. So our goal is to be able to extend that and optimize our screening coverage and reach many more people across all the countries where we work. So we are going to start with a prioritization in high burden countries and particularly focus on the children, older adults, and people with advanced HIV disease. To supplement that, we will be doing the comprehensive strategy, expanding our TPT coverage, and we're excited. Atul made reference to the new short course TPT regimen, which I would like to give a little shout out to CDC, because I know it was CDC collaborative research that really helped on some of the discovery and ultimately the WHO approval of that. So thank you to CDC for that input as well. I want to share one thing. When I started this this position, a very seasoned global health person said to me, you know, you have this goal of ending HIV as a public health threat. Make sure that HIV is not another TB story. And I paused for a minute, and at that time I said, and I will say tonight, again, my reaction then and PEPFAR's commitment tonight is that we can and we will make both HIV and TB success stories. And I want to thank all of you, because it will be partnership with all of you here to do it, but we are completely committed from the PEPFAR side to doing that. So thank you so much.
Thank you. Thank you so much. Thank you so much.
Reauthorize PEPFAR.
Woo. Woo. Thank you so much, and I hope you feel the energy and the commitment. And I don't know when we had so many leaders saying so convinced that yes, we can end this disease. So I don't think we should accept even through our heads to go a moment of doubt. So going at the leaders thinking that we can end TB, I'm looking at you, Teresa, as the WHO director of the TB program. We have even a bigger set of targets in front of us, including on TPT for the next 5 years. How WHO, through guidelines and recommendations and the tools and the facilitate the achievements of these targets, and hearing all these commitments here.
Inspiring. Good evening, dear colleagues, and Luchika, with your permission, I will follow your example and will go a little bit beyond the exact question. So it seems this is the evening of big announcements, and I would say not only evening but the whole week. And today probably you are very busy from meeting to meeting. One important, another is also exciting. So it's great. Maybe you've missed today's press conference when we launched a status update on the progress toward the targets, and I have some good news for Salman. So picture looks a bit better, and according to our 40 million targets, we managed to achieve to provide by treatment 34 million. Is more than 84%, which is not good at all. Keeping in mind the impact of COVID pandemic on us, it means that altogether, community, healthcare workers, officials, we've done, partners, of course, we've done a good job, and it's reason to be proud. And related to TB preventive treatment targets, of course, progress, it's more modest, much more. I would say 15.5 million people were provided, and of course, the subpopulation picture looks differently, while I think, again, for people with HIV, almost 200% achievement of the target. It's big success and big opportunity to learn and also accelerate efforts towards other targets. And now we are moving to a new set of targets. And if someone is asking, questioning, do we need really targets? Indeed, we need. And they are real drivers. These targets, they're meaningful. And today, during press conference, there have been questions. So why we have TB-specific targets and we don't have UHC and PPR-specific? This is our achievements and reason to be proud. TB is given as an example. And this is also great. But when I'm looking at the topic for today, it's broader than just TB preventive treatment. While it's unnegotiable that TPT is extremely important, but preventing is broader area. And that's why another reason for optimism was yesterday's launch of WHO together with the partners years. And it was historic launch of the first ever TB Vaccine Accelerator Council. Of course, vaccines are playing extremely important role. And even a few years ago, we couldn't even imagine that there could be vaccines in the pipeline. Now we have 16 vaccine candidates. Some of them are very promising, and with joint efforts and investments, of course, we and learning lessons from the COVID experience and the same platforms, we can have, we believe, within next 5 years, real more effective candidates, and we should work all together. So prevention agenda is absolutely essential, and the reasons why it was not prioritized, it's essential basic knowledge from the medical colleges, from the university, we all know, but the reasons were different. Of course, chronic lack of funding and maybe lack of awareness and adherence to prevention, but now it's time to change this traditional way of working, and really without addressing prevention in broader and concrete meaning of TPT, there is no chance to end TB, but we should do it. I will end to can and will should. Thank you.
Thank you. Thank you very much. Yes, we should, and we will. Going to this, I want to go to you, Dr. Zucker. We are together in this event organized with your team. Thank you so much for all the work of the team that you have, but also not in organizing this event, but on the ground. So, CDC's has good plans for increase the efforts both domestically but also globally in addressing TBT. So can you share with us a bit about these plans?
Sure, thank you very much. And I want to thank the CDC Foundation, Stop TB, and the CDC Division of Global HIV and TB. So Claire, we all are in agreement that the common goal here is to prevent and to end tuberculosis. And as we've heard, TB remains one of the most critical public health challenges. And in fact, it is actually, from a single infectious disease agent, it is truly the leading cause of death in the world. And that's despite being preventable and treatable, which is sad to hear. As we know, TB also remains the leading cause of death for those with HIV. We heard that right from the beginning when Lois was speaking about that. And every day, 4,000 people die, and 1.6 million people have died in 2021 from tuberculosis. So tackling the epidemic is absolutely one of CDC's primary issues. And we are leading on this in the United States, and we are leading on this in 25 countries as well. CDC's efforts in the U.S. include many efforts on cutting-edge research, as well to strengthen our global impact on this. So, for example, CDC has a TB trials consortium, the TBTC, and that leads on the clinical trials in the United States as well as worldwide to shorten treatment. We heard obviously the benefits of shortened treatment. Atul mentioned that a little while ago. And we want to complete the treatments faster. We'll obviously keep more compliance there as well. In the U.S., CDC supports the dual approach to finding and treating active TB cases and to test and treat in the latent TB cases. We heard about latent TB earlier today as well, earlier this evening. TB's preventive therapy helps prevent latent TB from becoming active and becoming tuberculosis. So we want to address that as well. And we're prioritizing this approach through the CDC's Think, Test, Treat TB campaign, and we're working hard on that. And still many people suffer from tuberculosis. We've heard all about those challenges globally. Globally, CDC is leading efforts to develop and implement programmatic initiatives and approaches to find and treat key populations. So one example of that is the tuberculosis preventive therapies, TPT. You heard a little bit about this as well. CDC supported 62% of PEPFAR's TPT efforts worldwide, and through PEPFAR's support, CDC has led global efforts to exceed the UNGA 2018 TB preventive treatment targets for people living with HIV. CDC was responsible for 6.8 million individuals completing life-saving treatment, and we also have led on diagnostic, programmatic, and laboratory innovations as well. And that's increasing the understanding of drug-resistant tuberculosis as well. I thank Atul and USAID for their financial commitment. These are a great great success stories, and we all work together to achieve this. So thank you, Atul, very much, and your team. CDC's mission to protect America from from health, safety, and security threats in the United States and around the world as advanced by our efforts to prevent tuberculosis. By identifying the hotspots that we find where there is TB and identifying and breaking the cycle, we will be able to achieve the goals of preventing further spread. We also work to prevent importation and spread of TB into the U.S. through TB testing and treatment on U.S.-bound immigrants and refugees, and we've heard a little bit about some of the challenges with migration as well. And this is done through our Cure TB program, which connects people with tuberculosis to healthcare services as they move between the United States and other countries. Working with our partners, whether it's WHO, our global health ministers, our CDC is helping to bolster systems needed to prevent, to find, and to treat tuberculosis through our efforts to strengthen lab networks, surveillance, obviously, and clinical systems. And one example is this, is that we're working in Eswatini, Malawi, Tanzania, and Uganda. And we've worked with local health ministers across the world to evaluate these screening and diagnostic methods to diagnose children with tuberculosis. And I saw those numbers that you presented about children with tuberculosis, and as a pediatrician, that really touches me. Expanding access to newer, shorter treatment regimens is also important, and we have rapid and accurate diagnosis of tuberculosis, and also multi-drug resistant tuberculosis cases as well. CDC is effective globally because of our collaborative approach, and working with our Stop TB partners are collaborating on a project entitled Re-Imaging Tuberculosis Care, and that is also working with many individuals where we can identify when, where, how, and what services need to be provided and supported. With support from the CDC Foundation, we have been involved in the implementation of a Bill and Melinda Gates Foundation funded project called Preventing Occurrence of Tuberculosis by Expanding Coverage of TPT for those with people with living with HIV/AIDS. And that's called Project. And the aim of Project is to understand the overall impact of TPT scale-up and TB incidence and mortality. So we're working on this in 6 countries, which include Haiti, Uganda, Zimbabwe, Ukraine, Nigeria, and Kenya, and we believe that we'll be successful in that. CDC remains fully committed to ending tuberculosis as a global public health threat. When we all return back here and talk about this in the future, we want to be sure we've achieved the goals. When we go back to our countries, it is important for each of us to be committed to this as our shared goal of preventing and ending tuberculosis globally. And the problems we face are interconnected, and so the solutions are connected as well. And I will leave in just a little artsy statement, because we're in an artsy environment, and that it's very interesting that years ago, in the 18th and 19th century, tuberculosis was romanticized. I mean, it ended up in operas, and it was sort of until Robert Koch in 1896 actually identified Mycobacterium. And my first time I ever heard about tuberculosis was when my family took me to see Verdi's La Traviata right here at Lincoln Center. And I said to my father, what happened to her, Violetta? And he said she died of tuberculosis. And so I feel like what we should do is get to the point where tuberculosis is left with the arts because of the science that we are doing to eliminate it in the world. So I thank you very much.
Thank you. That was an amazing end, and thank you so much for making this link. And I want to just share with you that today the Minister of Health of Indonesia also made an ending to an intervention that he made. He said that he looked over Wikipedia to see some things about TB, and he said there were different chapters, like the tuberculosis in the early, tuberculosis in Africa. He said, I want all of us to write a chapter that will be in Wikipedia, how we ended TB. So really awesome alignment here. Speaking about alignments, Eliud, how are you? Eliud is actually himself a warrior on TB and a strong believer in preventive treatment, by the way, as we debated many times how we should do this. How do we make the doctors and the nurses prescribe and people take it? But how can Global Fund, what can Global Fund do to to help and support countries to increase the TPT coverage.
No, thanks, Rushika, and good evening, colleagues. Many greetings from our Executive Director, Peter Sands. He wanted to be here, but he had some family issues, so he couldn't be here. But I would like to thank the organizers, CDC, CDC Foundation, Stop TB, Partnership, and everyone USAID for this meeting. And also, it seems like we have a week of good news. Today's news is fantastic for us, for everyone, especially at the Global Fund, where now we are receiving funding requests from the countries. And what we have seen in this funding request, countries are very ambitious. They are more ambitious now than before. 5 years ago, our struggle at the Global Fund with partner Rushika and others, it was that we were seeing that TB was not ambitious in terms of the goals, in terms of the funding absorption, in terms of the scaling up of new tools and innovation, but this is not the case. Now TB program is absorbing just like HIV or malaria. Our absorption rate is above 80%, which is above even the KPI we put for ourselves, which is 75%. TB programs are now more ambitious in terms of the targets. When we review, for example, the window one funding request, which was the first one, we had 19 countries which applied for tuberculosis. The funding gap in those countries was more than 500 million. We have not seen that level of ambitions coming from TB. So they put what they had in the allocation, but also they were able to identify areas which they could be able to support if there is more funding. So that level of ambition we are seeing from countries. I think with this announcement of Rifampicin, announcement about TB cartridge, gene expert cartridge, announcement about bedaquiline, will really help countries to be able to bridge that gap and be able to put more patients on treatment. And my friend Salman, I think that's a very good challenge, and I believe it's not a challenge to Global Fund, because what's a Global Fund? Global Fund is a partnership, it's all of us. So it's a challenge for us, and I think, yes, funding is a problem, but there are other problems when it comes to putting people on TB preventive therapy. And in the Global Fund, TB prevention is a priority, especially in our new strategy. We make sure that we are very intentional when it comes to TB prevention. We believe we cannot end TB without really be able to have a dent on TB prevention. And our approach is not only one item or another. It's a comprehensive approach. And Dr. Anyaika was very clear. We need to really look at the prevention from all angles, and we really need to focus on that. What we did in this funding cycle, the new funding cycle, we made sure that first, prevention is mentioned in our strategy, but also we put what we call modules. So those who are applying for Global Fund, they know. We have a specific module for prevention. It was not there before. It was the TB care prevention, so a lot of things together. But we were able to put it separately, and that is an incentive for countries to focus on prevention. And we put clear indicators which are related to that. And when our TRP are reviewing the funding requests, they make sure that what you put in your narrative match with the budget. So we think that will help countries to put more money on the TB prevention. In the current funding cycle, which is ending, TB prevention was about 8% of funding in the TB, and we hope that will increase with the next funding because of the priority and the attention which we put in the TB prevention. And also we are tracking what countries have put in their funding requests. So we are tracking at the level of funding requests when they are submitted in terms of how much countries have put in each module. But also we are also tracking at the level of grant making, because there's a lot of shifting and making sure that the countries are really focusing on those priorities. And we will be able also to track that during implementation, just to make sure that countries are focused on that. I think one of the challenge, and when we were making this strategy, we did a review under our technical reference evaluation group on TB prevention, and we were trying to see what are the challenges, what are the barriers for countries to scale up TB prevention. And one of the challenge many countries highlighted was they thought they don't have enough tools. Cost was one, but also enough tools, to be able to do that. But there's also hesitancy from a lot of clinicians. So this is a work which we really need to do at the country level, working with that. But also, one thing is that we don't need to do prevention as a separate program. It has to be integrated into routine program activities, especially with case-finding activities. So we must make sure that it's efficient, is sustainable, but is also integrated program. It's not a standalone program, and that's what we really need to do to make sure that the execution part, we get it right. So I'll stop there, but just to say that apart from the money we have in the regular grants, we are able to get more money from C19 RM. This is the mechanism for COVID. And TB was able to get a lot of funding. The funding, the request from countries was overwhelming TB. And this has allowed countries to be able to buy equipment such as chest X-ray, more gene expert, which we think will be able to help with scaling up TB prevention. So thanks for that.
Thank you. Thank you, Eliud. Thank you, Eliud. You give some hope, but you give also worry. A gap of 500 million only from one round means that Global Fund has a lot of fundraising to do to cover those unfunded demands. So I'm going to Sahu now. From the Stop TB, we are very proud on the fact that we try to bring together ministers, civil society, technical partners, private sector providers, industry, in coming together towards the effort to end TB. But tonight is about EPT. How can we use these partners? What should we do in the partnership? And we didn't even discuss before, to really make sure that we help, we shoulder here to achieve the TPT targets.
Thank you, Ruchika. So let me start by saying that Stop TB does many things, as Ruchika said. We aggregate partners and we do a lot of awareness advocacy. Some years ago, on a World TB Day, we decided, led by Ruchika, that we should test people in Geneva for TB. Some interesting discussions happened, and I realized that was an excellent awareness generating activity. Many people from Stop TB, Global Fund, WHO got tested. Some got positive. I was positive also. Ruchika as well. That led to some interesting questions, and we realized that testing is a beautiful way of creating awareness. Things that you don't know, and then you start working on it. So this was a very unusual way of generating awareness in Geneva. But let me, because I realize we are running late, just two things here. We from Stop TB have been doing some work, not just on advocacy, but some concrete things to help countries. For example, the TB Reach initiative has now started 19 projects in 13 countries, $10.8 million committed to help countries, partners, local partners, to generate evidence how to do things with TPT, testing, whom to test, shorter regimen, how to implement, and that is a valuable thing that generates local evidence for local policy. And you all know about the global drug facility that countries use to procure drugs, and excellent announcement. Countries can procure 30% more now with the same money. I wanted to quickly come to one point that I wanted to focus. And this is about, we should be now thinking about contacts, because we heard about TPT, that we are failing the contacts. And the COVID pandemic showed us how important contacts are, right? So for any infectious disease, contacts are very important. The time is now for us to put contacts at the center of the TB response, and I will tell you why. 3-4 points. Number one, every TB patient, before the person becomes a patient, was a contact first. And every such TB incidence is our failure to protect the contact. It's infectious disease, right? So that is from a person's perspective. If you think about a national TB response or global TB response, if you think about next 2 years, who are the people who will get TB? Salman told us the recent contacts, right? So if you are able to address the contacts of today, we have the science to protect, we have the science for the TPT. If we can do that, then we will be preventing the next 2 years TB. And we should then be able to be ahead of the curve, right? The third thing I wanted to also point out why contact is not just for TBT. If you are able to reach out to contacts, do a contact tracing, contact investigation, you are diagnosing TB early. And you also have a benefit to put them on TPT. So it's a dual purpose tool, right? So and the point about integrated approach, and this is the integration, the contacts. And the last point I wanted to also make about contacts is people are discussing about pandemic preparedness. There was a full UNHLM on pandemic preparedness. Any new pathogen starts spreading, where would you focus? The contacts, right? Maybe later on in the pandemic, your capacity to deal with contacts gets overwhelmed, but in the beginning, it's the contacts. So if we can build a system for contacts using the TB model, that is pandemic preparedness. Now, just the last point, I think this point about TPT hesitation that was mentioned is very important. So we would request to reflect on it. I would like you all to think about something. We are all very excited about new vaccines coming. A vaccine and TPT could be similar efficacy if you look at the current candidates, right? If we are not able to do a good job in TPT, we will not be able to do a good job in vaccine. These are healthy people at risk that we have to protect. So one way to get prepared to scale up vaccines, new vaccines that are coming, is to focus on TPT. Thank you. I will add that.
Thank you very much. 3 things. This is why Sahu is with the brains and I'm with the big mouth in the Stop TB. The second point, the campaign for testing in Geneva's offices was because I really hoped that Peter Sands, who at that time was just joining SED, is infected, because then if people are infected or sick, are caring more about TB. And few of us here in this room, I'm looking here at Salman, I think I look at you, John, as well, loved Paul Farmer. And I don't know if you remember, Salman, when we were having some drinks in Paris, and he said that a way to increase awareness is to make some leaders sick with MDR-TB. And we were even discussing how, but I'm not going into details. But he was right. So that's why we did that entire campaign. And the third point, going on a serious point, you see, we have almost 11 million invested with TB Reach into how TPT works. So there will be a lot of richness coming from these projects, which are showing some of the barriers and what will really happen that we hope we will provide to WHO, as we did with other situations, to help with the guidelines. With this, we are very pleased you stayed with us so late on a Friday, on a Thursday evening, but before a long Friday tomorrow. We want to thank you very much, and I want to thank this amazing panel. Amazing announcements. Thank you. And the closing moment will be a photo all together. What what a great closing we will have. So I don't know. I think if you can stand up, and that's right, Anand, right? Or it's like. I'm saying something. Come on, Anand. Come. We don't have all speakers, but Salman, can you jump? Salman, can you jump on the stage somehow? She can. He can. He lost weight now.
I wouldn't say I totally saved it. I'm gonna be honest, but I saved this